Thank you very much. It's an honor to be a part of this. This is a very ambitious program. What I'd like to do is present in the time that we have remaining a talk that I've given from time to time and sort of picked up on because a colleague of mine had to write a very big grant, and so I took over the presentation of this, a course called The Design and Conduct of Clinical Trials at Mass General that I ran for 10 years. As I was saying in informal comments earlier, everybody's bored by randomized trials because they feel that they understand them perfectly. It's sort of like febrile neutropenia, which is something that I recently studied. Everybody knew so much about it they wouldn't talk about it. Same thing with design the randomized trials. Everybody is certain they understand them fully. So let's see if that's the case. Fasten your seatbelts. It's going to be a fast ride. All right. So the content today consists of the advantages of randomized trials over observational studies, other non-randomized experimental studies. We're going to talk about the structure of randomized controlled trials, which determines the question that's specifically asked, not the broader question, the primacy of randomization and the efforts that are required to preserve it, blinding, some aspects of data analysis and presentation, ethics, stopping rules, and a final skitter through controversies in randomized trials. So here are the basic points. And you're going to hear this a lot, and ultimately you're going to be hit over the head pretty hard. The purpose of randomized clinical trials is the design most likely to produce valid conclusions about treatment efficacy. In other words, outcome differences, if any, are most likely due to the therapy under treatment rather than confounders or other nuisance variables. It is the most powerful technique available to answer the narrowest of questions. So keep that in mind. The fundamental trade-off is internal validity. That is protection against challenges to the validity of the conclusions for external validity. That is decreased confounding and bias, but reduced generalizability. I think we have a sense of the former, but the latter is often forgotten when results are interpreted. So let's get to one more point that sort of emphasizes a point that I raised at the last presentation, which is to remember that randomized controlled trial results are not the truth. They're just one experiment. Even the FDA, in terms of approving drugs, requires that there be clinical benefit demonstrated in studies, more than one, which is a recognition that the results of a single trial are not all we know. And we should not, we need more than one experiment to reach a decision about the null hypothesis, whether or not to reject it. RCTs are the theoretical gold standard study design. And it's important, I think, if you're trying to use an alternative strategy to conduct a thought experiment, randomized controlled trial, not renal cell cancer, when designing a non-RCT study. As my clinical research mentor, Lee Goldman, I guess who's now the dean at Columbia, used to say, when you're thinking of doing a quick and dirty study because the most rigorous design isn't possible, keep this in mind. Quick studies are never remotely as quick as you think they're going to be, but a dirty study never gets any cleaner. It's useful to reveal the potential challenges to the validity of your alternative research plan. I advise strongly trying to think this through. There's too many, there's a real tendency that I see over and over again to compromise on the study design, the result of which is you get ambiguous conclusions. A well-designed study puts you in the leadership. I found myself an international leader in doing in febrile neutropenia because of one well-designed study. Every time you collect data, and particularly if you collect data in the most powerful fashion available, you know more than everybody else. Keep that in mind. Okay, RCTs versus observational epidemiology. Why are observational studies okay for toxic effects, but not for therapeutic studies? Duh. You can't do RCTs of toxins. Obviously, to get an ethics board to approve a study, the study has to have a reasonable chance of benefiting the patients. If your best chance in a study is to break even without toxicity, nobody's going to improve it. Practically, they have very different historical roots. Observational studies of toxins are done by epidemiologists, whereas the world of clinical medicine is involved in observational studies of therapy by clinicians who also, unfortunately, don't have a lot of study design expertise. And I think that comes into play when we talk about analysis later. By the way, can people read these slides? You guys are okay back there? All right, sorry about that. Interventional studies therefore require more scrutiny than observational studies. Institutional review boards, data safety and monitoring boards are involved to make sure that we don't surreptitiously allow toxicity or the perpetuation of unfavorable treatments to persist. Now, what are the primary problems with observational studies? The primary problem is confounding by indication. Patients receiving medicine or a procedure in the clinical world are different at baseline from those who don't. And here are 3 quick examples to show you why. Prednisone for asthma. What kind of a patient gets prednisone rather than beta agonists, inhaled steroids? They're the sick ones. So comparing the 2 populations is confounded by the indication that led to their being treated for prednisone. Using insulin in type 2 diabetes is very similar. Most patients can get by on oral agents. If you use insulin, you got a sicker patient. And there's also the potential of confounding by contraindication. People don't give warfarin to patients that have a demonstrated risk factor for bleeding. So if you're trying to compare patients getting warfarin versus patients who are not, you are highly likely to find confounding in the opposite direction. This is a core stumbling block for non-experimental outcomes research. Now, let's talk a little bit about that fundamental trade-off we talked about for randomized controlled trials. If you look at this and see if I can make my pointer work. Whoop, nope, 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 nope. Button. Nope. Oh, there's a button. Got it. Okay. Using the button. Oh, thinking I had the button. Oh, there it is. All right. This is supposed to represent a funnel. And you can see if you're trying to ascertain and recruit patients, you have to identify a population. Then you send them through an eligibility screen, which reduces the patients. For example, for some reason, any patient who's had a cancer of any sort in the past 5 years, other than skin cancer, like a basal cell or squamous cell, can hardly ever get into a cancer study, even if the study is for advanced lung cancer, where the median survival is 4 to 8 months. Patients are excluded for reasons that are extraneous. Finally, there are the patients who consent to the study. Now, there's good evidence that patients who are willing to consent to a randomized, seek out and consent to a randomized trial are healthier than those who don't. So all in all, we have a whole lot of, well, I still can't figure out where that, oh, there's the button, it's red. Then and only then do we get a chance to look at the validity of the studies. So pre-randomization assesses generalizability by selection, the impact of run-ins, which I'll talk about in more detail. Post-randomization has to do with challenges to validity, preserving the benefit and validity we get from randomization, so excluding patients from the results, loss to follow-up, compliance, contamination, Contamination is obviously when patients who are assigned not to get the treatment get it anyway, off protocol. Co-interventions, other sorts of treatments that are instituted outside the protocol, and finally, in terms of assessing the outcomes. Randomization, the purpose very clearly, and you've heard this over and over again, but it can't be said enough. The purpose of randomization is to balance both known and unknown confounders to ensure that both treatment groups have comparable risk of the failure outcomes at study entry. So we start everybody else on average at the same point. It doesn't matter what your method is other than this. So you can use a preset list of random numbers by table or computer, ongoing process by cards in a hat. In a study that I did, patients were randomized on weekends, so we had a set of envelopes that were available. But it has to be random. It can't be by the day of the week, alphabetical last name, hospital number, something that's potentially knowable by the investigator, because as soon as that happens, the investigator can steer certain patients toward the study or not, based on the likelihood that they'll get an intervention that the investigator thinks of, i.e., confounding by indication reappears and asserts its ugly head. So that's what we usually get in Table 1 of a randomized trial. This is this so-called sportif trial. It doesn't matter what it is. What you can see is, because there are lots of patients, and you can probably barely read it in the top line, but it's almost 2,000 patients per arm. I'm sorry, it's almost 1,400 patients per arm. With a study of that size, you will almost certainly get almost exact equivalence in the measured variables. That assures us, provides us visual assurance that we don't have, that we are balanced in terms of unmeasurable confounders. Now, you don't see any p-values there, which I think is a good thing. There's been a trend to move away from that. Again, I had a trial that, in part because it had a much smaller accrual than planned and had block randomization, which I'll talk about, ended up with some imbalances. The reviewers asked me, do you have any speculation as to why there were these significant imbalances in pretreatment characteristics? My response, I could speculate all I want, but the only answer is sometimes, by chance, there are uncommon outcomes. The p-value is how likely is it that these results would happen by chance if there's no difference? Sometimes rare things happen. All right, so what are some experimental alternatives to randomized controlled trials? Well, they're using historical controls, which are somewhat related to time series, probably not. The point is that there are different patients that are being compared. And they're certainly not of the same time period. Therefore, you can state something like, our new nursing system led to shorter length of stay. Well, you don't know that. Why not? Because secular effects, as well as unmeasured confounders, because again, it could be different patients. Who knows that a more sophisticated, healthier, better insured patient might not go to your hospital because you have a new nursing system. And it may invalidate the comparison. It's definitive only when the historical experience provides a firm expectation of an outcome, and by firm, you can imagine that that means you're going to die. So liver transplant for biliary atresia, a child will not survive without a liver transplant. Imatinib for CML, Ceridase for Gaucher's disease. These are horrible outcomes that if you show a good outcome, that's pretty good news. That's sort of like the classic randomized trial of penicillin back in the day for pneumococcal pneumonia. 80% mortality versus 100% recovery. The remedy is, well, there are some others. There's a series of on-off N of 1 trials. There are trials to diminish secular effects and time series analysis. So before and after N of 1 studies, you use the individuals as their own historical control. Sounds great. There was a big vogue, I don't know, 20, 25 years for this sort of thing. The advantage is you get what seems to be perfect matching. I mean, you got patient 1 versus patient 2 is patient. But that's not always the case. First of all, it's only applicable in certain conditions. I'm a cancer doc. Doesn't apply to anything I do. Further, the match isn't always perfect. An individual's condition may change. And if you have, again, a cancer patient who is, say, tried on something, maybe something for hypercalcemia, and the cancer progresses, you no longer have a perfect control. You have patients in different circumstances. However, it provides the conceptual basis for a crossover randomized controlled trial where the order of treatment is randomized. And here's a crossover trial. Treatment A is given to subject 1. You get outcome A. Then there's a washout period in which all of the effects of the treatment have presumably disappeared and we're back to square one. Then subject 1 gets treatment B. We get outcome B. Crossover RCT is good for a chronic condition like hypertension or repeating conditions like epilepsy, where individual variation is much less than inter-individual variation. You're trading time for subjects. You double the number of subjects by more than doubling the amount of time for the study. Order and washout effects are critical conditions. Make sure you randomize the order. Be aware that there may be some consequences of the initial treatment that do carry over. Is the washout period adequate? Then there's so-called before and after studies. This gets us to the problem of regression to the mean. I know you've heard about it. I think the most interesting highlighting of regression to the mean came from a very nice analysis that reinterpreted the entire placebo effect as being largely produced by regression to the mean. It arises from this. When patients are selected for an extreme value, there's two possibilities. That extreme value could be representative of their condition and they're really sick, or they could be drawn from a much larger population of healthier patients who happen to have an extreme value at that time. So if you select for extremely high blood pressure or blood glucose or pain, at study entry, less extreme values are more likely on follow-up. For example, the data that I will show you here for the UGDP study, again, back in the day, looking at various treatments for insulin. Randomization mutes the regression to the mean because we presume, on average, the patients are equally likely to regress to the mean. So here's the UGP study, and all I want to do is show you this one point here, which is 1 hour. Whoosh! Whatever the treatment was, including placebo, was really, really, really effective at lowering glucose. Now, there is another solution that's sometimes put out and has to be beaten down in sort of a whack-a-mole process. People say they can match on known confounders to mimic the effects of a randomized trial. The most recent version of that is propensity indexes, which try to adjust using a multivariable model, not for the measured confounders, but for factors that might lead somebody to get a particular treatment. It's the same thing. It is, if randomization balances known and unknown confounders, if sample size is large enough, but if you just match on known confounders, you've only gotten part of that taken care of. Again, you can't address the problem of unknown confounders by trying to match, no matter how you do it, even if you use something that sounds like it's very hip and cool. There's a wonderful paper that I've been trying to track down for a couple of years from time to time, which looked at 6 or 7 major innovations in statistical sciences and their utterly almost random penetration into medical clinical trials. And for some reason, propensity indexes were popularized by somebody that I know, at least in cancer, in a trial, and everybody's picked it up. Like, again, it's a solution to a problem. There are no magical fixes for these sorts of things. All right, some more I did that because I figured by now you're starting to fall asleep. So from time to time, you'll get a little of this stuff. If the sample size is small, you can balance critical confounders by stratification with blocking. Now, stratification is something, again, that you need to understand. The purpose of stratification is efficient comparisons, or, more to the point, avoiding really bad comparisons. So if you don't do any stratifying, your likelihood of, for example, ending up comparing a 98-year-old male to a 50-year-old female increases. Now, that is a comparison in which you might detect the influence of the treatment, but far and away more likely is that those differences are likely to be washed out. So the purpose of stratification is to constrain the impact of randomization. It costs you something. There are no free lunches. You're a little less certain that patients are matched, are balanced on measured and unmeasured confounders because you've constrained the result, and that's why you should always minimize stratification. You can always do stratified analyses, but when you stratify going in, you're constraining the effect of chance in order to avoid inefficient comparisons. So you can do it by, for example, doing block sizes, and you have a random sets of blocks. So you get 4 patients, 2 treatments, A and B, and you can see there are various permutations, and those should be done randomly. It's useful even in large trials because you want to, again, make sure you're roughly comparing like to like. So if you have a big trial and expect a lot of enrollment at each center, you can stratify by center, you can control by calendar time, new blocks per year to protect against secular changes, or to assure balance in critical covariates. There we go. You can also do cluster randomization. In health services research trials, you can randomize patients by physicians, physician practices, or hospitals. Why? Because what you're measuring is not totally independent by patient. It involves an interaction between the patient and something. So that's another way to eliminate potential bias and do the randomization by the appropriate unit. Now, one more thing, although I can't imagine why somebody would do this, but random allocation of therapy in a randomized controlled trial is obviously not the same as randomly selecting patients that are receiving a therapy for clinical reasons. All right? Subjects are representative of that treatment, but they're confounded by indication. All right, hey, there's another one. There'll be a little bit from time to time. Pre-randomization processes affect generalizability. So when you see a trial, make sure you ask, who are these patients? To whom do the results apply? Most importantly, do they apply to my patient? In oncology, patients almost never have even performance status 2, which means symptoms that significantly impair their function. When we see cancer patients and are considering them for treatment, and particularly so-called salvage treatments, they're usually very sick. Almost certainly, if we extrapolate based on healthier patients, we're overestimating the benefit for patients and underestimating the toxicity. Post-randomization processes affect internal validity. Since randomization assures valid comparison groups at baseline, the goal is to preserve randomization. Again, I'm going to be drawing, a lot of these things come from general medicine. I'm going to draw my examples from oncology. In a very famous case, there was an overeager investigator in Montreal in a breast cancer trial who was so eager to be the #1 accruer that he stretched the rules. And so patients were enrolled in the study after a specified time period between surgery and treatment. Now, the kind of person who stretches the rules one way can stretch the rules the other way. And he certainly did a couple of other things as well. But far and away, what he did was stretch things to increase his accrual. The result was women testifying in Congress in tears, they had no idea if the treatment that they were taking was efficacious. The answer was, it certainly was. This was, although a very large accruer, he was less than 10% the study, but most importantly, all he did was slightly increase the generalizability of the study by including patients who would have been excluded. That does not affect the validity of the conclusions. And when they reanalyzed the data, the changes in the results were correct to the 10th of a percentage point. Now, going back to threats to randomization, post-randomization exclusions, they may be unavoidable. For example, if you're testing a treatment for myocardial infarction and you don't know if the patient is diagnosed, then that's unavoidable. You can still do intention to treat, you just have a less efficient study. However, some things can be particularly prone to bias. For example, if you have a surgery versus radiotherapy study in which patients have to be have resectable lung tumors, the patient is randomized to surgery and the surgeon says, nope, too far advanced, can't do the surgery. Obviously, if you throw those patients out, you're going to get a very biased study, although a lot of surgeons like those. Therefore, you always have to have complete accounting for post-randomization exclusions, and it's always better to reduce, minimize, and ideally eliminate such exclusions following intention to treat. What about compliance failures? You can, first of all, try to ensure that the allocated therapy is taken by a variety of cool methods. For example, pill containers that send a signal when they're open, that sort of a thing. You can also do primary intention to treat analysis. But, we'll skip this. We don't have enough time. But let's look at the coronary drug project. This is a good example of the idea of looking at trying to look at compliance as a measure of efficacy. In this study, clofibrillate was randomized to patients versus placebo to try and reduce secondary cardiovascular death following an MI. And the final results of the study looked like they were stone cold negative. But the investigator said, wait a minute. Yeah, it doesn't look good, but let's look at who actually took the drug. I mean, we're testing a drug, right? And here's what they got. And that's 2/3 reduction, or 2/3 more mortality in non-compliers. So what's the next question you ask? Is there a difference in people who are compliant or not with the placebo? And it's exactly the same. For example, you can't comply when you're too sick. You can't comply when you're dead. And that's the kind of problem that comes up when you try to do post-treatment exclusions. Now, if you do a run-in period, pre-randomization, you can probably weed out the non-adherent, but it brings you back to the trade-off. You're more likely to get patients who are compliant with the treatment. You're going to get a better, more thorough assessment of the intervention, but you're going to distort the outcomes. What's the impact of weeding out non-compliant patients from your population on the generalizability? Does somehow studying a group of patients who are non-compliant guarantee that the drugs are only going to be given to patients that are compliant? If you want to have an understanding of what the impact of the drug has got to be, it's got to be real world, and that's efficacy versus effectiveness. What about toxicity? If you eliminate people who don't take the treatment because in the run-in they're feeling too sick, they don't want to take anything, how is that going to influence the reports of toxicity?
Jim?
Yeah.
Do you think for those who are unfamiliar with the concepts of run-in period, could you just do a brief...
Oh, sure. Does it,
and also intention to treat. People are probably not familiar.
Oh, okay, sorry about that. A run-in period simply says, let's do a run-in period in which we give patients a treatment and say, here's what we would like you to do. So here is the placebo. And they determine which patients are actually taking enough of the placebo, usually around 80%. Patients who aren't complying that well are felt to be poor risks for the study, and if you've got limited resources, let's spend our money on the patients who are taking the treatments. But, as I said, it affects generalizability. Intention to treat simply means the comparison groups are determined at randomization. You are entered into the trial, you're assigned a treatment, therefore you are followed forever, even if you don't comply. The reason for that is that you need to make sure that you're not distorting the analysis by doing something that's very easy, which is to say, well, these guys didn't do very well, but they didn't comply, they were too sick, they were run over by a bus, whatever. It doesn't matter. It's a way to distort, it'll distort the outcomes. Now, let's talk about blinding, because blinding is important. Remember, randomization is the main guarantor of validity, assuring similar risk of outcomes at entry. All right? Blinding assures that post-randomization treatment is fair and balanced, i.e., the co-interventions and outcome assessment are the same in both arms. It doesn't do you any good to have patients that are similar in the beginning if they're treated differently thereafter or the outcomes are ascertained differently. That reintroduces systematic bias and confounding. Again, the goal is to make sure that the differences are solely due to therapy. So, blinding adds credibility, but it also adds complexity, costs, recruitment hurdles, ethical issues, and it may not be practicable. For example, sham surgery. That seems a little extreme. And yet, without sham surgery, we would not have known from a very important VA trial that certain kinds of endoscopic knee surgery are worthless. That's the only way you could possibly do it. Sham blinding, for example, using beta blockers and warfarin.
What's that?
Sorry?
Sham blinding?
Sham blinding is it's hard to blind, but you actually have to not only say that you're blinding, but actually come up with the sort of monitoring that you need to do. You have to have rules for how you're going to treat the patient that may or may not reflect exactly what's going on. So you blind patients, but you have rules for how you're going to treat changes in clinical conditions down the road. Hard versus soft endpoints. Remember, the purpose of blinding is to prevent human interventions from affecting the outcomes. Now, there's two ways of doing that. It can be affecting additional treatments or measuring outcomes. If the treatments are pretty straightforward, obviously you need to monitor it. If your outcome is mortality, there's no ambiguity. You know the result. It's clear cut. So again, in cancer treatments, if the outcome is mortality, you don't have to worry so much about blinding, particularly in ascertaining the outcomes. Now, blinding may hinder assessment of the real-world impact. For example, injections versus pills in diabetes. If everybody's going to get a pill and an injection, you don't really call into play what happens in the real world. People don't like needles. They'd rather take pills. So you're going to get an abnormal, a distorted view of compliance in the real world. What about quality of life? Similarly, if everybody's getting the same treatment, there might be a quality of life benefit, say once a day versus 4 times a day treatments, needles versus pills, and so on. So IV versus PO antibiotics in the hospital. You might lose the length of stay economic effect because PO antibiotics don't necessarily need to be given in the hospital. The point of the comparison is to show that they have similar efficacy, but the ultimate goal is to try and reduce length of stay or reduce the cost of administration. If there's no blinding, try to consider how biased co-intervention could affect the outcomes, and then try and institute remedies. You can address this partially, but only if you acknowledge what the goal is and what the problem is. Now, assessment of cause-specific outcome events. That's something, again, that there has to be blinding. If you are, for example, aware that somebody's had a radical prostatectomy for prostate cancer, there's good evidence that someone is less likely to put on the death certificate that they died of prostate cancer than otherwise. There tends to be a systematic distortion that's outside the setting of a trial, but it's data that's sometimes used. You can get the same effect if you have a committee that's trying to determine cause-specific outcomes. You need to have careful planning, criteria that are as objective as possible. And then there's the problem of events, outcome events that happen so rarely that whoever is working them up may not even know that the protocol exists or that the patient was ever on protocol. So again, you can get patients for whom there's varying degrees of evidence to try and determine what the results are. So it can always sneak back in. So when you're thinking about this, think about what signals an event. Is it that the patient reports something or that they are seen in regularly scheduled examinations? So you're going to detect it, whether or not you have variability in patient reporting. Which events are pursued, what information is collected, and are out-of-hospital deaths informative? All of which are complexities that are sometimes addressed by these sorts of committees. Whoops. RCT data analysis is generally fairly straightforward in contrast to observational studies. Someone once said if you are doing an epidemiologic study, you only need somebody if you have a relative risk between 0.6 and 3 or an increased risk of between 0.6 and 3 because outside that range, nobody's going to believe you. People will believe you on the high end, regardless of your statistician. Nobody's going to believe you on the low end. So what are the issues? Control of unbalanced covariates, loss to follow-up, deaths from so-called competing cause, and the fiction of non-informative censoring, and analysis by intention to treat, and again, efforts to try and preserve the primacy of randomization. So, measures of effect. It really matters how you present something, particularly if you're trying to have an impact of a relatively low-frequent event. This is something the cardiologists have been legendary for years. There are various ways to present the outcomes. There can be a relative risk, which is how have you changed the likelihood, your ongoing risk of a bad outcome. Risk difference, what's the absolute difference that you obtain? Relative risk ratio, and the number needed to treat. In other words, how many patients have to get treated for anybody to get 1 unit of benefit? So, for example, if you look at the total mortality in the Scandinavian Simvasten survival study, or 4S, there were huge numbers of patients. The overall outcome was overall survival with a mean follow-up of 5.4 years. If you look at the risk ratio, the risk R sub 0, the placebo, versus R simvastatin, the risk ratio was 0.67, actually, because of rounding, blah, blah, blah. The number is closer to 0.7. So you've reduced the risk by 30%, correct? The relative risk ratio is 1 minus the relative risk over 100%. Oops, I don't know if I have that right. Oh, I'm sorry, I have it wrong. The lower one is correct, but it gives you about a 30% relative risk ratio. The risk difference is the absolute difference, which is 0.04. There's a 4% absolute difference in mortality at 5 years. Not trivial, but not as immense as 33 or 67%. And then there's the number needed to treat, which arises directly from the risk difference, which is 25. So 25 patients have to be treated for you to get 1 patient still alive at a median of 5.4 years. So be careful when you're thinking about the time period, 5.4 years. If that were 50 years to get that sort of number needed to treat, the cost and benefit analysis would change. Just going to run through some more ethics, some more issues. Equipoise. I don't know how many people are comfortable with the concept, but the idea is it is not ethical to enroll somebody in a trial if you feel the answer, if you have a valid scientific belief that there already exists an answer to the question. There are plenty of things in medicine where people are convinced they know the answer to the study, but the science isn't there. So you have to have a solid belief that the answer is unknown. And usually an IRB does a good job of assessing that. Clinicians, as a rule, suck at it. Informed consent, just remember that there's a difference between documentation of informed consent. All of these things are written by lawyers, not by clinicians. Informed consent is an ongoing process. The point of the informed consent document is to simply provide a convenient way for you to, for both parties to signal that they understand what's going on. But usually they're horrible documents. You know, they're 5 pages long. They list, you know, they're like the little, the things that they say at the end of the drug ads, death and blah, 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 and they terrify patients. But informed consent is a more significant process. There are certainly situations in which patients are coerced, and they can be coerced by their setting, i.e. being in a prison or an institution. They can be coerced by their disease, which is terrifying, a highly fatal disease. And of course, there are tricky issues in children, and obviously that's bigger than what I can do here. Now let's talk a little bit about data monitoring and early stopping rules. Now this is something that historically it's always been there. The question is, if you have a randomized trial, at what point do you stop it? And the issue is, if you have an efficacious treatment, how can you keep going on and not offering that treatment either to patients who are enrolled in the trial or patients who are about to be enrolled in the trial? In other words, if you're on the trial, you can stop it and cross patients over to the active treatment. It really came to a head during the AIDS era, the early AIDS era, when scientists wanted to conduct studies, and the patients said, look, we're going to die. We've got that historical control. We're going to die. Just give us the medications. That carried on in breast cancer patients, and that sort of patient advocacy world extended. What's interesting is historically, the strongest patient advocates pretty soon began to realize that it's not a great deal. It's not a walk in the park to get unproven toxic treatments for a highly toxic condition. And most of the patient advocates from that era are very, very strong supporter of rigorous clinical trials, because patients aren't benefited. First of all, patients aren't benefited by getting probably not efficacious treatments that are highly toxic. And the science goes bad because people falsely think they have an active treatment and they can't enroll patients in trials to find out what's really true. It's an important balancing act, but a DSMB or DSMC tries to ensure that, as well as statistical methods known as sequential trials design. Early stopping rules are designed to protect subjects from taking therapies that are proven inferior. The significance level for those kinds of studies has to be a lot lower than 0.05%, the conventional endpoint when you're designing a trial, if you have an interim look. You know, one way is to, there's a couple of ways to do it, but one of them is just to say, go 3 standard deviations instead of the approximately 2 standard deviations from using a 0.05. Because you're taking multiple looks at the data, you're cheating. You're trying to turn one experiment into multiple experiments. You can't do that. You only have one shot from your trial to get evidence. And if you keep looking at the data and changing the results based on what you find, or your conclusions based on what you find, it's cheating. Now, obviously, this doesn't apply to toxic effects of treatment. Once you discover that a patient is toxic, then that's a different sort of a question. And in general, we tend to shift our reaction to toxicity differently than the more open question of efficacy. Now, what's the impact? What has happened through the course of the years is the early stopping rules have gotten more lax. Why? Well, it's related to that historical process that I described. If you stop, first of all, you can bias the results. If you stop when you hit a certain result, And frankly, those studies back in the old days were often stopped when somebody got a positive result. Some investigators would run the p-values every month and publish when it got below 0.05. But most importantly, you run the risk of wasting the whole study. If you stop too soon, as soon as you stop a study, you reduce the power. You have less data, larger confidence intervals, and it limits subgroup analysis, which is not a huge benefit. And it also inhibits the repetition of the study. So if you do a big study, you stop it early, and then you follow the results, and you find out you didn't really answer the question, it makes it wastes all of the resources, including the patients who went into the study, and it also makes it a lot less likely that you're ultimately going to get the answer from another trial. So it's the trade-off between the interests of the participants, the individuals who would arguably want to get their treatment decided based on all the information there is, even if it isn't persuasive, and the interests of the larger population, which want a valid treatment that is really proven and wants its resources steered toward efficacious treatments, not non-efficacious treatments. If the patient's conditions are chronic, patients revert back into the general population and they benefit. All ethical rules are less vexing if the condition is chronic because the trial results directly serve the subject's need. In a diabetes trial, it doesn't matter that much if you don't get efficacious treatment for a couple of years. That's not true if you have AIDS in 1985 or pancreatic cancer. A couple more controversies. They regularly, just talking about controversies, RCTs are always controversial. Usually concerns design or analysis issues. The debate may clarify the issues, but if you really want to solve a problem, you don't talk about it, you collect more data. Now, some people talk about the idea of one big trial, a sort of ISIS approach, where you have a simple trial, you make a phone call, you get 45,000 patients in 6 months, and you answer the question and get wonderful generalizability, very powerful data. Others, when you have conditions that are less common, then what you can do is have planned iterations or have randomized trials planned to be built into a meta-analysis, in which case you can try and consolidate the data and make it better. But ultimately the question is, yes, you can quibble with every trial. There's always a problem because we're not using lab rats. But if there's a clear question that you want to resolve, the way to do it is to collect more valid data, not argue about the data that you have. Now, again, just touching on some points that we've made before, generalizability. Patients in trials tend to be highly compliant. They tend to be healthier. They tend to be different from the average patient. So be cautious in applying the results of treatment to patients that are very sick, because almost certainly those patients were not in the trials. The implementation, the applicability of therapy, type 1 versus type 2 diabetes. They're completely different diseases, even though they're called diabetes. The significance of the outcome, particularly surrogate endpoints. Everybody's impatient to get an answer. Therefore, we take shortcuts. The shortcuts use surrogate endpoints. The surrogate endpoints don't always work. For example, using control of blood pressure versus stroke. We're not doing it to control blood pressure. We're doing it to prevent stroke. They're not the same thing. Ventricular ectopy versus sudden death. Coronary calcium to control coronary calcium versus clinical coronary artery disease, that you show up on an X-ray. Progression-free survival versus overall survival. If you have a study in which you are randomizing a patient to an active treatment versus a placebo, you know before you do the study what progression-free survival is going to look like, assuming your treatment is efficacious. And yet, oncology is riddled with studies like this. Subgroup analysis. Just keep in mind that, in general, nature is not so subtle that It is highly efficacious in one subgroup, but not efficacious in everybody at all. Just be very, very skeptical of subgroup analysis. And this is a graphic aid that helps us sort of perceive that you tend to have fairly consistent results, but it allows you to sort of scan briefly in a hypothesis-generating way for subgroups in which you might want to pursue. No difference trials. We don't have time for that. What time is it? Do we have any time left at all?
4 minutes.
Oh, 4 minutes. Holy Toledo. Phew, huge. Never mind. It still doesn't get this. Well, just talk a little bit about no difference trials. No difference trials are complicated in two ways. One of which is when you're trying to reduce the amount of treatment that you normally do, like keep patients who are being ruled out for myocardial infarction in an ICU versus going home. For me, home care for low-risk patients with febrile neutropenia. They're tricky because you have to know how little difference is good enough so you can do something that feels like you're sort of shortchanging the patient. Similarly, if you have new agents in the other way, in which you're trying to show no difference, in which the new agent is somebody who's got a longer patent life and is almost certainly more expensive, pay attention to those trials. Blah, blah, blah. Okay, what about the, again, use of controversies? Do you use a placebo or not? The FDA likes using placebos. The question for the clinical question isn't does the thing work? The clinical question is does it work better than what we've got, particularly if it's newer, more expensive, and has side effects that we don't fully appreciate. What's the appropriate non-inferiority margin? As I said, what is equal enough for us to feel comfortably giving up on what we know? Intention to treat versus treatment received, well, you've heard that. Was standard therapy given optimally? Sometimes you find the control group does a lot worse than you would expect, and you wonder what's going on. Finally, if there's no difference between the standard and the new therapy, how can we be sure that the new therapy actually worked? Well, you'd have to assume that standard therapy doesn't work very well either, but you can see the kinds of knots that you're put in when you try and design the study. For prevention trials, they have long studies with low event rates. It's kind of hard to keep them going at high quality, and they are at risk for obsolescence. Surgical trials, what's the unit of analysis? Is it the patient? Is it the surgeon? It's the team. We do health services research studies to look at volume outcomes ratios. We've certainly established that for complex procedures, it's better if you do a lot of it, but what's really causing it? If they're unblinded, we talk about the impact of co-interventions, as we've described earlier. Finally, the balance of outcomes. A definitive trial is usually definitive because it documents efficacy, but that doesn't mean that you've got a definitive clinical decision. Decisions depend on a mix of benefits, costs, and risks. RCTs do a good job of assessing benefit, but risks and costs aren't done as well. So the decision needs to be individualized, of course. So, for example, if you have a large relative risk but a small risk difference, you might come to a different conclusion. I would always argue for looking at the risk difference. Big picture, what is the clinical question? The trial design determines the question that gets answered. If your question is, does antibiotic A work, or whatever drug A works, you get a different answer if you ask the question drug versus placebo, drug versus current best antibiotic, drug versus the specific target, the percent of pneumonia versus the percent of pneumococcal pneumonia that's cured. Similarly, does anti-cancer drug B work? Tumor shrinkage versus some sort of clinical benefit or overall survival. I'm hitting you over the head with this. Big picture. The design determines the question. Entry criteria. How the treatment is given. Which events are the outcome events? The sum of the choices specifies the specific randomized control question, and keep this in mind. Not all clinical questions are answered by a drug trial, even though that's what you see mostly in the literature, because that's where the financial incentives are. So think broadly. Thanks.